Some of you may only have kind of a week or two. Some of you may, still have another month or so. I wanted to do this webinar to recap what you can be doing in these final days. And in terms of my journey to PACES, I did it a while back now, and I was not on a training scheme. I was a locum doctor in A&E, so I've kind of been there where I know it's hard if you're not on a training program to track down patients, find people to practice with. And I know a lot of you are in that situation where you're already on the back foot, so don't worry. It's definitely doable. Um, Feel free to ask questions as we go along. Many of you may know we hold PACES courses, and the next course is actually next week, starting on Thursday for our 4-day course and Saturday for the 1-day. And the September course is actually sold out now. I had a couple of you messaging me saying if you could join the 1-day. It may be possible. I'm just trying to open up some more space. I'm limited by the venue in terms of the numbers of rooms and the numbers of patients we have. But if I can open up another room and get a few more patients in, I may be able to get a couple of you onto the September course if you message me. But that's not, it's not hard and fast. We still have spaces on the October course. So, if you are looking to come on a course, please do come along. We try and show you as many nice cases as possible. We have one instructor by the bedside with every patient. That's our aim. And yeah, we've had some really nice feedback in the past. And even if you don't want to join our course, at least join our WhatsApp group where we post about these free webinars. So top right QR code takes you to the course page, bottom right takes you to the WhatsApp group, and I'll probably post a link to the WhatsApp group in the chat. So, okay, so I did a similar sort of slide back a couple of months ago, and I just want to remind you guys that PACES is a game. It's not rocket science, right? You kind of have a rough idea of what's going to come up. Okay, in respiratory, you're probably going to get ILD. In cardio, you'll get some weird valve or congenital disease. In neuro, it's probably going to be Parkinson's. But then there are weird and wonderful things which can pop up as well, which you may never have seen before and just have no idea. So you need to find a way to navigate this game. And it's all about showing off to the examiner. You do this stuff day in, day out. If I told you you're on an acute medical take and you need to go clerk a patient with syncope, and then you need to go clerk a patient with tingling in his feet, etc., you would have no problem with that. But when it comes to the exam, obviously the stress and technique is what it comes down to. You guys have the skills, you do this day in, day out. You are all kind of medical SHOs or registrars, and you just need to show to the examiner that you have a simple, logical way of thinking and that you are capable of being their registrar. Some statistics, so the pass rate is approximately 50%, and this varies based on if you're like a UK graduate or on IMG. And IMGs do tend to do worse. The reason I put this in there is because we do have a decent number of IMGs coming on our courses. So that's not to kind of knock your confidence. That's just to let you know that, okay, maybe there's certain areas if you're an IMG that you need to look at to really prepare. And usually that's around communication, how you kind of convey your presentation, and just kind of, yeah, these little tweaks. The areas that people perform poorest in are identifying clinical signs and coming up with like good differentials. So we'll cover some of this in a bit. But now, where are we? Okay, so we've got days. Some of you probably got weeks, and if you're lucky, some of you might have your exams kind of like later on, early December-ish, late November, so you may have a bit more time. So it doesn't matter what you've done till now. If you're prepared, then that's excellent. If you feel like you're underprepared, which is probably most of you, because you can never really be fully prepared for this sort of exam, it's not too late. This is now the most important time. Every day that you have till your exam is really valuable, and you can turn it around from knowing nothing to giving yourself a really good chance. So don't be disheartened. There's no point of like just feeling down and think, oh, there's no way I can do this, because that's not going to help you now. Okay, you need to make the most of these days. So this is how I would prepare. Let's say if I had my exam in a few weeks, or it's kind of around the corner. Step one, examinations. This is your focus, because every part of the exam consists of examinations except communication skills. Okay, so this should be your focus. Your exam routines have to be slick. And I said this before, and if they're not slick by now, okay, they should be, but if they're not, that's fine. It's not a hard thing to perfect. You've only really got 4 exams to nail, and that's cardio, resp. Neuro, you can split up into cranial nerves, lower limb, upper limb, and then abdominal. And then you have a few ancillary ones, like, okay, you might want to learn how to examine for inflammatory arthropathy of the hands, for example, but that's kind of a bit more niche. These 4 exams you must nail, and you can probably do that in a weekend. So that you've got Saturday, Sunday now. What I would do is I would just um, go onto YouTube and you could type in, isn't it, cardiology examination and watch someone do it and make sure your routine is perfect. I would have a checklist of all the things that I want to do in my exam. So for cardiology, for example, start off with inspection. What are the things I'm inspecting for? Okay, now hands. What are the things I'm looking for on the hands? Okay, then after that, blood pressure. Okay, the water hammer pulse, etc., etc. Work your way around the body, have a checklist. Don't cram every possible technique into your examination because you must be able to do this within 5 minutes. I know you've got a bit longer in the exam, but in pressured situations, you want to give yourself that leeway. So when you're practicing, do it on healthy individuals, family, friends, colleagues. If you don't have anyone, just practice it on a pillow or something. You want to be able to nail your examination within 5 minutes. So don't put every single technique under the sun in your exam. It's not going to aid you. It's not going to get you more marks. You don't need to do focal fermitus and tactile fermitus, for example. Do one or the other. Um, if you're assessing for hepatomegaly, you don't need to do every test under the sun. You don't need to do the scratch test, for example. If only if you feel like it's going to help you in that moment, you can do it. But keep your exams brief. Make sure you've examined for all the key things. Have a checklist. You can film yourself as well, if the person consents, obviously. I'm not talking about patients, but I'm talking about healthy individuals like friends and family. Film yourself, look at it again, critique your technique, improve, and keep going. And yeah, just figure out a routine that works for you. So once you've got your examination routine nailed, which you should be able to do in a weekend, you kind of probably all practice these extensively at medical school. And I know when you get onto the wards, you don't really do the whole spiel and routine, but it's not hard to pick up again. This is the next part of step one. Have a list of cases that you must see on the wards. And I'll go over what these cases look like. And this is based on what most commonly comes up. Prepare for the things which are most common, the things that are rare and wonderful, like yellow nail syndrome or something. You just have to go with the flow on the day. You're not going to see that in real life, realistically. What I would do is have a list of cases and then try and bunch cases. So being like on Monday, okay, I'm going to go to the cardiac ward and I'm going to listen to 5 murmurs. And then if I listen to 5 murmurs, hopefully 3 of them will be aortic and 2 of them will be mitral. So I'll have a good idea of what each one sounds like. Tuesday, I'm going to go to the neuro ward. I'm going to examine 5 cases, hopefully one central nervous system case, one extrapyramidal case, hopefully one lower limb neuro, one upper limb neuro. I know it doesn't always work out like this, but I think this is what would be most useful, is to see volume of cases of the same type of examination in the same day. If that's not possible, it's not a problem. Just whatever you can get your hands on, just do it. But make sure you're seeing as many cases as possible in hospital. And the way you can do this is, I'm sure you will have that kind of PACES WhatsApp groups in your hospitals. Email the general medical consultants, asking them for interesting cases every week. You may have 1 or 2 who get back to you. Stay late, come in early. Maybe you even need to come in on a day off, like if you have a 0 day or something. Just come in on the morning and examine a few patients, and be resourceful. You only need to do this for like 2 weeks or so till you have a good grasp of the main cases. For those of you who aren't in a training program and who are like a locum and don't have a firm grip in any hospital, which is what, the position I was in, you just kind of need to find So I was looking in A&E. So I found like medical SHOs who were sitting the exams whilst they were on their acute take, and they added me to the WhatsApp groups, etc. Um, People like to teach, people like to help, so don't be scared to do that sort of thing. The final part of step one was the viva, right? The examinations is the viva. So you're going to have a list of common topics. And now you need to think, okay, so in neurology, Parkinson's is a common topic. So what are all the questions they can ask me for Parkinson's? Okay, well, I don't know, pulmonary fibrosis. So interstitial lung disease, idiopathic pulmonary fibrosis, that's a really common one. So what are all the questions the examiner could ask? And you can just run through these. And I found a really helpful book for this was Cases for Paces. It's probably maybe a little bit outdated now, because I kind of read it back in 2019, but it was really useful for the Viva stuff because it's like, these are the common questions and these like three short points you can use to answer them. Um, and here I've got another example. So like, what's the echo criteria for aortic stenosis? Like the velocities and valve areas, etc. Practice these questions in your head. So you can just ask these questions to yourself and you can answer them. Get colleagues to grill you, get consultants to grill you. This is the only way that you're really going to get better. So that's examinations done, and you should be doing that regularly. That is the bulk of the exam, right? And feel free to ask questions, by the way. I haven't seen any come through yet. But we'll move on to clinical consultations. So don't neglect this because this is two whole stations. Yeah, it's station 2 and station 5. And for those of you who are old enough to remember, this didn't always used to be like this. There used to be just a station 5, which was quite similar, and that's the one I sat, where in one station you would see two patients. Was it two patients? Basically, it's quite similar in that you'd have to examine the patient and take a history of the patient. Um, but they've kind of just made this, they've stretched it out into a longer version where I think they give you some bloods and things to interpret before the station. And then you need to go and take a history, examine the patient, and then explain the diagnosis back to the patient. It is pretty similar to the station 5 that I sat, but like I said, don't neglect it because this is 40 minutes of your exam. Have a list of cases. This one's a little bit more tricky to prepare for because the cases are quite vague. And I've got, speaking to people who've sat it, our candidates who have sat it and thankfully passed, I struggled to hone in on like three really common cases. They all got a bunch of really vague presentations. They weren't hard. It's all stuff that you would see in your medical take, like syncope, infections, anemia. But they're quite broad categories. So I think the best place to practice this would be SDEG or ambulatory care or whatever you call it in your hospital. Because that's exactly the type of patients that come, you always get patients with syncope, anemia, workup for recurrent chest infections, that sort of thing you'll find in SDEG. But obviously that's not efficient because you never know what's going to come through an SDEG. For every 3 or 4 patients you may see, only one might actually be relevant to your practice. So practice with colleagues over Zoom, and this one's really effective. And I know someone who's done this, and they spoke very highly of it. And the way they did it is they would create scenarios for each other. Obviously, you can't examine. So what they would do is they create the scenarios, and then they would take the history. And then when they get to the examination bit, they'll be like, okay, now I'm going to examine you, and I'd like to examine your neurological system for X, Y, Z, your cardiac system for X, Y, Z. And then the person who's the acting patient will then give them the examination findings when they ask for them. Um, it's just a way, that you can navigate the examinations bit. You should be doing that with colleagues as much as you can. There's plenty of people in the WhatsApp group. Hopefully, I know some of you kind of tried to make a group, so I hope that's going well. Timekeeping is key. Remember, you've got 15 minutes. Leave the final few minutes to actually speak to the patient because you need to explain the diagnosis and what's going on. And the patient, obviously it's PACES, right? They're going to have like a few concerns. They're going to be worried. They're going to be anxious. They're going to be like, oh, am I dying? That sort of thing. And you can't address those concerns in 1 minute. And if you don't address the concerns, that's one of the domains in the PACES mark scheme is like patient welfare and like addressing their concerns. If you don't do that, you risk failing that particular part of the mark scheme. Okay, communication. So this one is widely neglected. It's obviously a lesser part of the exam, and that only makes 20 minutes of the exam. But again, it's still really important to focus on because if you don't communicate effectively in the communication stations, you risk failing on certain domains. I've got a hand up, a couple of hands up by Talia and Amardeep. If you guys want to, you can just put your questions in the chat. You're more than welcome to ask. Okay, so don't neglect communications. Have a list of cases. So this one is there are a few cases which is rinse and repeat, breaking bad news, explaining a medication error, DNA CPR, dealing with an angry patient. This is all stuff you've probably done a few years ago at med school. And it's the same stuff that comes up over and over again. There's just a bit more technique to it, and that the patients, there may be certain things you need to navigate, like how to explain a DNA CPR. You might need to know about DVLA guidance. That's one that came up in my exam. I think I had a patient with multiple sclerosis, a new diagnosis of multiple sclerosis, and she was having visual issues. So these are bread and butter things that hopefully, if you have a list of cases, you should be able to nail. This is nice and easy to practice, really easy. Just create a few scenarios. And I think the MRCP website actually has a few mock scenarios. You can practice with colleagues over Zoom. Have a script of things that you find difficult to explain. So I'll give you an example of this, but one might be DNA CPR. Have a script, memorize it, internalize it. Okay, you should know off the tip of your tongue how to explain to a patient DNA CPR. You don't want to, the first time you're explaining it shouldn't be when you're in the exam, because then you're gonna accidentally say something silly, like, and that could put you in trouble. Timekeeping is key. Remember the basics. So I know a couple of you messaged me and saying like you tripped up in certain areas in the communication station, and that's go back to basics. The examiner will be looking for this sort of stuff. So are you signposting? Firstly, have you introduced yourself? Have you signposted? Have you checked in with the patient? Don't use jargon. This is a big one I see, and I think often actually with IMGs, I've noticed that they tend to use big words. You just need to break it down really simple, as if you're talking to your younger cousin or something. Just don't use jargon. Ice, you have to ice. I'm sure we've all probably been told this a million times, but I think the place where people slip up in is they ice. They'll be like, okay, so what do you think is going on? Okay, what are your concerns? And then the patient will say their concerns, be like, oh, I'm really worried that this medicine is going to harm me. And then they'll be like, okay, thank you for telling me that, and they'll move on. But that is a cue. You need to pick up on cues. So if a patient says something like, oh, I'm really worried about this medication side effect, you need to explore that. So that's where it's not just actually asking the question, but you need to explode it and explore it and be like, okay, well, why is that a concern of yours? And then the patient will say something like, oh, well, 5 years ago, my mom died of some weird side effect. So these are the things that in the patient's script, and they'll wait for you to ask them. And if you don't ask them, they won't tell you that information. Summarize at the end. Please remember these basic points, because this will help you pass the communication station. And this is an example of a script. So I'll give you guys a second to read that. But this is for DNA CPR, and it's something I posted in the WhatsApp chat before. But it's an example of a sort of script that you can make to help you explain things in the exam. I won't read out, I'll just let you guys kind of have a quick read of it. Okay. So I'll probably send these slides around, so don't feel like you need to kind of take pictures, etc. Sorry, just bear with me 1 second. Okay, cool. So hopefully you've all had a chance to read that. I've had a question come through. I'll answer that one at the end if that's okay. It's a good question though. Okay, so now you've prepared for your examinations, your histories, your communications, and clinical consultations. This should all be happening in the background. Don't forget to do your basic reading. I liked Cases for Paces. I'm not sponsored by them or anything, but I really enjoyed it. I like things which are short and sweet. I can't handle big textbooks. I had the I had a bigger Paces book, but I didn't really. I mean, I use it as a reference, but I think for me, I like things which I can cover in like a weekend. And Cases for Paces is something you can cover very quickly. I think it's like 100 pages long. Um, YouTube videos, there's so much content out there. There's even video banks, but like there's so much free stuff on YouTube. And I remember back in the day looking at there was a doctor. I can't remember. I think it was in maybe Stoke. It was Dr. Punica. He's really popular. I think he's got like millions of views on some of his videos, but he was a PACES tutor and he has some really nice videos on YouTube. Um, Courses, obviously, like, we run courses, but I'm sure, I think if you're sitting the exam, it'd be really wise to go on a course. And like I said, we do run courses, even if it's not my course, you make sure you try and get onto a course. Okay, here are the common pitfalls. So poor timekeeping. This is why practicing is really important and your examinations, making sure you're nailing them in under 5 minutes. So when it comes to the exam, 6 minutes is a breeze for you. Timekeeping with regards to clinical consultation, just make sure, like I said, you leave sufficient time at the end to actually speak to the patient. Communications hopefully will be less of an issue, but you just always keep in mind, have some sort of way of tracking the time, whether it's you can have like a little watch on your belt or something. Don't get flustered. I know it's an exam and it's stressful, and you might walk into a just be prepared that you probably will walk into one examination station, have no clue what's going on. You'll be like, I've never seen this in my life. I don't even know what this scar is. I don't even know where this heart sound is coming from. That's a gate that I've never seen before in my life. But that's fine. You just need to find a way to navigate that. Don't just break down. Just, work your way through the examination and describe what you've seen to the examiner in your presentation as best as possible and come up with a reasonable differential. So, I heard this heart murmur, which is most likely coming from the aortic region. It's in keeping with a XYZ pathology. Other differentials would be this. As there's a degree of diagnostic uncertainty, these are the tests that I would do to confirm my diagnosis. So I'd like an echocardiogram, ECG, etc., etc. So that you just need to come across as professional. And actually, if you're not sure and you come across as professional, you still have a good chance of passing that station. People fall into the trap of not keeping it simple. They think paces, so this is going to be something rare and wonderful, and come out with the most rarest differentials. And that's where you'll fail the differential diagnosis bit. So remember when I said people slip up on identifying signs and differential diagnosis. If you come up with a differential which isn't reasonable, then you will slip up. And I say this time and time again, and I'll say it later. Just list the three most common differentials, and that is enough. You don't need to list four, five, six, even three might be a bit much, but if it's really obvious, you might not need to list three. Like if it's Parkinson's disease, it's Parkinson's disease, right? It's not going to be like Huntington's disease. But you could say, okay, this is in keeping with Parkinsonism, of which the causes are idiopathic Parkinson's disease. Other causes, although less likely in this instance, would be a Parkinson plus syndrome or Lewy body dementia. That's it. It's not rocket science. Verbal diarrhea. When you're under stress and pressure, and we've all been there, I'm the same, you can just start waffling. You can keep, whether that's in your communication station, whether that's in your Viva, you just keep talking and keep talking and keep talking. So be concise. Remember, the examiner on the other end is a human. And think about if you're an examiner, would you want to hear something short and sweet and to the point, which just ticks most of the boxes, or do you want to hear someone kind of keep talking? They would have seen so many candidates by the time they've seen you. So keep it short. Failure to develop patient rapport. So remember, this isn't all an act. It doesn't matter how you practice in real life. It doesn't matter if you feel like you're a bit awkward or introverted. For these 2 hours of the exam or however long it is, you're an actor looking to tick the boxes of the examiner, who's essentially you're in an audition, right? That's the way you should see it. So be really open, have a smile, speak with confidence, speak with clarity, make sure you're icing and not just icing for the sake of icing, but actually exploring the concerns, like I said. Make sure you're ticking all those boxes, like summarizing, checking in, etc. You might not do that in real life. Come on, let's be honest. How often do you ice in real life? But it's not, sadly, this is not representative of real life. It's an exam. So you need to tick these boxes. Okay, what I'll do is let me go through. I've got a couple of questions coming through. So what I will do is let me go through the next 2 or 3 slides, and then I'll take some of the questions and then we can continue. Okay. So like the examiner's perspective. So if I put myself in the position of an examiner, and obviously I've not been an examiner, but I've taught a lot of both medical students and doctors over the years, thankfully. What I would say is first impressions count, make the first minute count. If that's an examination, be confident, walk in with confidence, look like you know what you're doing, and you need to show the examiner you know what you're doing. You might be really good at examining, but if you're not showing the examiner that, like, okay, I'm having a proper look around the bed. So you need to probably be turning your head, looking around, looking at the floor, sort of thing, to actually show them that, okay, this person is properly inspecting. Um, so just exaggerate some of that stuff. Have a systematic approach. I'm sure most of you have this, but if you're examining, inspect, start with the hands, move around. If you're taking a history, obviously that's bread and butter for you guys, but start with history, presenting a history, presenting a complaint, etc. Make sure examinations are slick. If your examinations aren't slick and it looks like you're not sure what you're doing, then that's the examiner will pick up on that straight away. Whereas if from the get-go in the first minute, you've shown the examiner that you know how to examine, they probably start tuning out. Clear and concise presentation. So like I said, keep it short. These are my positive findings. These are the relevant negatives. This is my differential. This is what I would like to do next. And then that's it. Well-formulated differentials, 3 common differentials, move on. Respond to patients' cues. That's what, something that I'm sure examiners will be looking for. So these are the sort of things, but of all of these, it's the impression you give that is the most important. Because like I said, it's the examiner is human at the end of the day. If they see someone they think is like, oh, this guy, like he's really slick, he speaks well, his technique is good, he's clear, he's concise, you most likely going to pass that station. It's kind of the other side of it. Okay, you could have prepared as much as you want, but ultimately it is a mental game. Don't worry if you failed before. Many have failed and have gone on to pass. In fact, pretty much, most people who fail go on to pass. What was in the past is now in the past. Stop worrying about that. A lot of you kind of think about even, okay, I'm at this center. What's the pass rates? What cases have come up in the past? That's all useful, but ultimately what happens on the day happens on the day. You can't control what comes up. You can't control what the pass rates at your center are. It's a standardized exam. And all you can do is make sure you've practiced as much as you can. You've put in the hard work. Take some breaths outside the station, just calm yourself down, and then fall back on your practice. Stick to the basics. Don't do anything complex. Don't talk about rare, weird, and wonderful differentials. Good examination, good history technique, 3 simple differentials, and that's it. And prepare yourself that a station probably will go badly, but like it's quite common to come out of the exam thinking you failed, and most people who think they failed, well, not most people, but a lot of time when you think you failed, you actually pass and pass quite well. So it would be a real shame that if you're in the exam and you think a station goes badly, but in reality, you've actually done pretty well on that station. But because you think you've done badly, now you've got a negative mindset and it's going to affect the rest of your performance. and then that will actually lead you to fail. And that's such a shame. So if a station goes badly, just forget it. You've got four other stations to recover. Um, so it's fine. And this is what, from my days back a long time ago, back on the wards or in A&E or whatever, you get a bleep. Okay, nurse is asking you, you've got an angry relative here. Can you please deal with him? Okay, you go deal with the angry relative. Okay, medical registrar comes to you. Can you please clerk this patient with syncope? Fine, you go clerk the patient with syncope. Another bleep from the nurse. Oh, this patient wants you to explain their diagnosis. They have no clue, or the ward round wasn't clear. Okay, you go do that. Okay, medical registrar comes back to you and says, okay, can you see this patient with heart failure? And there's another patient with shortness of breath. Okay, then you go clerk them. Then the nurse bleeps you and saying, oh, this patient's having an issue. They're having side effects with this furosemide that you've prescribed them. Can you go see them, please? So this is the PACES exam, basically. It's what you do day in, day out, right? Like communicating, dealing with relatives, dealing with angry patients, seeing vague presentations like syncope, seeing bread and butter cases like shortness of breath and heart failure. So the point I'm making is don't think you're not good enough because you do this every day. It's just artificial in the exam and that there's an examiner standing there and you need to show off that you actually know what you're doing. This bit of the presentation I did back when I did my first presentation. So I'm going to skim through it because the recording is on the WhatsApp group. But what I will do, I'll just have a quick pause and I'm going to take 2 or 3 questions which have come in. So Yasmin has said, what are the most recommended textbooks? And thank you so much. Yeah, no problem. Honestly, I only used cases for PACES. I also had the bigger one. I think it's the Oxford one. Let me just look. I can't remember off the top of my head what it was called. I think it was Pocketbook for PACES. Um, if that rings a bell. But what I would say is cases for PACES. Like I said, I don't get any payment for mentioning them. I genuinely thought it was a really good textbook. It's about this thick, and it just covers the key points. Pocketbook for PACES was a bit bigger, and it was useful, but I don't like big textbooks. I like smaller textbooks. I just thought it was too much volume. And I've got, do you need your own ophthalmoscope, stethoscope, etc.? So you need your own stethoscope and you need your own watch. Obviously, make sure you're bare below the elbows so you can have your watch on your belt. Tendon hammers, the like orange sticks, all of that stuff should be there. Just bring your stethoscope. Someone's asking about ophthalmoscopy on the course. So I've thought about this, but I don't think it's a good idea. So I have a patient with diabetic retinopathy actually, and he's got quite good like scars and things on his retina. But I did think, should we get an ophthalmoscope, dilate his pupils? The problem is, and I've been on a course where we did do ophthalmoscopy back in the day, but like you have to dilate the patient's eyes, and then like 50 people come and examine this patient. I just think it's unfair on the patient, because ophthalmoscopy comes up really rarely in the actual exam. I didn't get it. Of all the candidates that I've asked that have been through our course, none of them have actually got ophthalmoscopy. So I think it's a waste of time on a course where you can only see limited number of patients to focus on something which probably 90% of the time will just never come up. If you want to practice ophthalmoscopy, go to your ophthalmology clinic. That's what I did, and just ask one of the ophthalmologists, like, hey, can I sit in on your clinic? I'm preparing for PACES. And then that's all you need, just one session. And to be honest, I've always found ophthalmoscopy difficult, but like the patient's eyes will hopefully be dilated in the exam if you do get that rare case. Someone's asked for how you dress. So dress smart in the exam, right? Like that's important, how you come across to the examiner. Dress as if you were going onto the wards, shirt and trousers, or smart dress for women. And did you do an eye exam on your MS case? It was a communication station, so no. Okay, cool. I'll take some more questions at the end. I'm gonna whiz through this bit because I've done this before, and I think many of you probably tuned into that webinar. So station one is respiratory and comms. Obviously, you've got 6 minutes to examine and then 4 minutes to present. Communications is 10 minutes within the patient, no interaction with an examiner. These are the common cases that I was talking about. By far, looking back at what our candidates have got, ILD, interstitial lung disease, is the most common. But these are your bread and butter cases. Lung transplant, obviously, that might be a bit more tricky to see, but you should be able to see ILD, COPD, bronchiectasis, scars, and pleural effusions in your like general medical wards. The one thing I would say, because a lot of you are going to get ILD, so know this inside out. And remember, there is a difference between ILD and idiopathic pulmonary fibrosis. Can anyone tell me what the difference is? I think candidates sometimes mix this up. So ILD is the overall bracket, right, of disease. So it's just interstitial lung disease. Fibrosis, it means that you have restrictive airways disease secondary to fibrosis, but idiopathic pulmonary fibrosis is one of the causes, right? I know it's idiopathic, but it's like one of the causes. And there's lots of causes of ILD. So if you hear ILD causes basal crepitations, right? But there's other things which cause basal ILD or basal fibrosis. So in your differential, you would say, okay, so these findings are compatible. Don't jump to idiopathic pulmonary fibrosis because it might not be that. But so these findings are compatible with interstitial lung disease with a basal predominance. Most likely, this is going to be idiopathic pulmonary fibrosis, but other differentials for basal interstitial lung disease include X, Y, Z. And obviously, if it's upper zone fibrosis, then your differential changes. So that is something you need to know inside out. An example of some of the questions they may ask you, okay, so what are the causes of basal and apical predominant fibrosis? They might ask you about antifibrotic therapy and they might ask you about spirometry. So you need to know the NICE guidelines for antifibrotic therapy. So when I was doing, I think it was pirfenidone, and there would be certain like spirometry criteria. Don't know if it's still the same these days. They might ask you about what you might expect to see in restrictive airways disease when it comes to spirometry. So your FEV1, FVC, all of that stuff. Um, and remember, when you're talking about management, so this isn't something I've got in the slides, but uh, a really useful way to structure the management is starting off simple, like with simple things like conservative measures, then medical, and then surgical. So just kind of breaking it down like that. And don't forget the basic forms of management. So yes, you have antifibrotic therapy, but what else? What are the basic ways you're going to manage someone with ILD? So that's a question to the chat. So I'm not talking about like, lung transplantation or fancy antifibrotic therapy. Like what's your bread and butter way of treating someone with any lung disease, really? Yeah, exactly. All of that stuff. So make sure you say it right. Okay, this is an MDT approach. We're going to do chest physio. That's a really important one. Smoking cessation if the patient is smoker. Um, those things are all really important. That's like you have to start there. You're not going to go straight to lung transplant or straight to antifibrotic therapy, right? Yeah, and similarly for COPD, you need to know the kind of workup in how you treat someone with COPD, the different inhalers and the stepwise approach, criteria for LTOP. Um, and yeah, again, this is something which you'll commonly see on the ward, so hopefully it's a bit more straightforward. These are your common communication stations which you're likely to get. So explanation of a diagnosis, explanation of a treatment, dealing with a mistake in a treatment. So you've given too much insulin, for example, dealing with an upset relative, something around DVLA guidance, genetic counseling, breaking bad news. Those are your common scenarios. And obviously the details might change. So instead of explaining diabetes, you might need to explain a slightly different diagnosis, but it's all the same process which you need to know. Station 2 and 5. So yeah, this is your clinical consultation. You got 15 minutes to take a history, examine and respond to the patient, and a 5-minute viva. And before the station, you have a brief like referral letter with some basic investigations like full blood count or LFTs or something like that. This one is a bit more difficult to nail down to a few common scenarios, and this is what I've chest infections, uncontrolled hypertension, syncope. Syncope is a really good one. Hematological issues like pancytopenia or sickle cell disease, weight loss and nausea, dizziness, fatigue, cough, loss of libido. So someone told me they got loss of libido and they were looking for a prolactinoma. Someone told me they got something related to Men's syndrome. So, it's very vague, but I don't think any of these are ridiculous. And I know some of them are a bit niche, but like men, but like most of these are things you would deal with again in SDEC or acute medical tape, like chest infection, malignant hypertension, syncope. I'm sure you guys have seen syncope time and time again. So just think about, have this list and think about, okay, if I get syncope, what questions am I going to be asking and what examination am I going to do? So break it down like that. Cardiovascular neurology station 3. So cardiology, this is your list, and by far the most common is some sort of valve replacement. Heart failure, congenital heart disease, dextrocardia, AF, connective tissue disorders, all these things can also come up. Neurology is the one that people fear the most. We've done two webinars on neurology. One was by an actual neurology registrar. One was by a general medical registrar. So you can check those out on the recordings. They're going to be far better placed to explain neurology to you than I am. But what I would say is common things are common. Parkinson's disease comes up time and time again. Peripheral neuropathies, so Charcot-Marie-Tooth, diabetic neuropathy, sorry. These things come up time and time again. And then yes, MS, cervical spondylosis, all these other things. I got cervical spondylosis. Patient had a scar on the back of his neck. He had increased tone in both of his legs. He had kind of a very spastic gait, had a catheter in. It was very classic. Now, yeah, you might get something rare and wonderful like Friedreich's ataxia. I don't think that's something you can really prepare for. Just prepare for the bread and butter stuff. Keep it simple with neurology. Break it down. Okay, is this a sensory issue? Is this a motor issue? And if it's a motor issue, is it upper motor neuron or lower motor neuron? Is it cerebellar or is it multi-modality? So if it's sensory, convey this in your presentation. So you'd be like, this finding is in keeping with a predominantly sensory issue, and these are my differentials. Or these findings are in keeping with a motor issue, specifically upper motor neuron, and my differentials are an old stroke, spinal cord injury, or multiple sclerosis. Okay, well, this presentation is in keeping with a cerebellar pathology, of which my differentials are alcohol, etc., etc. Or if it's multifocal, then say, this affects multiple modalities. The most likely differential is a demyelinating disease, such as multiple sclerosis. The more you can break it down like that, I think the better that comes across to the examiner, rather than just jumping straight to the diagnosis. It just looks more slick, in my opinion, to say, okay, this is in keeping with, then say the broad class of disease, like demyelinating disease, of which the most common differential is going to be multiple sclerosis. Rarer differentials include neuromyelitis optica. Okay, so you can say something like that. Abdominal comms, so comms we've covered, abdo, transplants. Like nearly, I don't know, nearly all the people I've spoken to have got a renal transplant. You might get a liver transplant, you might get an SPK. Some people do get things like PKD or splenomegaly. I got a patient with a weird scar. I think they had some previous bowel resection. But by far the most common is transplants. Make sure you've seen a number of transplants, know transplants inside out, know the signs of immunotoxicity. So, you can get gum problems, you can get tremors. Check if their fistula is working, because if they've got a working fistula, then you're thinking, okay, is their transplant failing? Check for access lines. You can comment on it. Check for peritoneal dialysis scars. You need to know this, off the back of your hand. Look for complications of transplantation. So have they got any evidence of skin malignancy? Do they have an obvious like melanoma or SCC that you can see on their scalp or on their limbs? Don't go out of your way to look for it, but just if you see it, then you can comment on it. So that's one way you can make yourself look really, really good. This is a format of presentation. So there's two ways to do it. You can either take them through your examination on the left. I'll put these slides up. I don't want to go through this in detail. I prefer the right, where I'd be like, I examined Mr. X, a 54-year-old man. I examined his cardiovascular system. My positive findings were an ejection systolic murmur radiating in the aortic region, radiating to the carotids. There was no evidence of heart failure. There were no, peripheral stigmata of cardiovascular disease. This is in keeping with an aortic stenosis, etc., etc. This is just much more simple for me to remember, but some people prefer the left, which is also perfectly fine to be like, okay, I examined this patient at the bedside. There was no paraphernalia of respiratory disease. On inspection, he looked well at the end of the bed. There were no peripheral stigmata. My main findings on the chest were that there was reduced chest expansion. There are no complications. These are my findings. You can do either. I prefer just listing positive and negative findings and then giving differentials. Or if you're really, really bold and you think you know the diagnosis, you'd be like, I would stay away from this one personally because you could get yourself in trouble, but you'd be like, I examined Mr. X, a 55-year-old man who has aortic stenosis. And the reason for this is because he had an ejection systolic murmur, etc., etc. I would stay away from that one because if you've got the diagnosis wrong, then you will not look good. Viva tips, rule of three, have three differentials at the tip of your tongue for pretty much everything. So as an example, splenomegaly. Okay, is it hematological malignancy? Is it an infection? Is it portal hypertension? Don't say something weird and wonderful like Gaucher's disease. It might be Gaucher's disease, but if you haven't mentioned hematological malignancy, then you look a bit silly saying Gaucher's disease. So that's my point. Three simple things: infection, malignancy, hypertension. That's it. So sorry, I know a couple of questions are coming. I'm almost done and I'll get to your questions, but just to test this point, you've seen a patient with hepatomegaly. Give me three common differentials. So you can put them in the chat. Yeah, perfect. Okay, exactly. Yeah. So cirrhosis, obviously cirrhosis later on, the liver shrinks, but definitely chronic liver disease with cirrhosis can cause it. Heart failure, cancer. Obviously, cancer is not, I wouldn't say it's common, but it's definitely up there on your differentials, isn't it? If you've got a big liver, it could be METs, it could be primary. So yeah, cancer, heart failure, and cirrhosis. So things like, so yeah, exactly. That's it. Don't say any more. So I know some of you said hemochromatosis and infection. So in the exam, your patient probably won't have hepatitis. It's possible, but they're not going to have an acute hepatitis anyway. And as far as I'm aware, I don't think a chronic hepatitis would cause a big liver, but I might be wrong. And they're unlikely. I mean, it's PACES, so you're right. They could have something like hemochromatosis, or they could have something like an autoimmune disease. So yeah, those are things worth bearing in mind. But obviously, at least list your common ones first. List your common ones first, and then you can work from there. These are your domains they mark you on. So they'll mark you on physical examination, identifying physical signs, clinical communication, differential diagnosis, clinical judgment, managing patients' concerns, and maintaining patient welfare. So remember when I said make sure you explore the concerns, that comes under this one, managing patient concerns. This is all on the PACES website. And again, I went into this in detail in my last webinar. So you guys can check that out. Okay, that was the final slide. Please check out our course if you haven't already. We've got space available for October. As I said, September is sold out, but I may be able to open up some more space. Just it really depends on if I can get another room at the venue or not. So if you are interested in the September, drop me a message. But I'm not making any promises. We'll try my best. Join our WhatsApp group, bottom right there. Top right takes you to the website, which is www.bitepaces.com. And what I'll spend the next kind of 10 or so minutes doing is I will um, I will take some of your questions. So let's go to the chat. Yeah, so the orange stick is used to check plantar responses. Someone said rheumatoid arthritis comes up a lot, I've heard. Yes, rheumatoid arthritis can come up. I probably come up in your clinical consultation station, or it can come up in the context of a patient with interstitial lung disease or bronchiectasis. So yes, definitely can come up in other stations. It's something to know inside out. Where can we find the recording from the neurology webinar? We have our Google Drive. I'll post it on the WhatsApp group that has all of our recordings on. So is a cardiology stethoscope allowed in the exam, or does it have to be a standard stethoscope? To be honest, I've only ever used a standard stethoscope. I don't see why it would be. I think you can take whatever stethoscope you want into the exam, but just double check with your center or see if there's any guidance on the RCP website. As far as I'm aware, I don't know if anyone else has had this experience, but I don't think it should be an issue to take whatever stethoscope you'd like into the exam, but just double check that because I'm not 100% sure on that one. Okay, what do we have? What is, I'll post the WhatsApp chat link in the group again. Cool. Do you have any other questions? Yeah, sorry, I know a lot of you've been emailing in about the course book. So I'm in the process of, we need to update it, which is why I haven't been sending it around. So just bear with us on that. It might take a bit longer than expected just because busy sort of sorting out patients for the course, but yes. And the patients for the course are looking quite exciting. So I'm hopeful those of you that have booked on, we should hopefully get a good experience. Okay, if you've asked about the recordings, all right, I'll put them in the chat in the WhatsApp group. So if you join the WhatsApp group, you can just click on the Google Drive and I'll have all the recordings there. Okay. What I might do is, if we're not getting any more questions, start wrapping up there. But